similar pain, yet require completely different interventions. One patient may present with a true radiculopathy with sensory, motor or reflex alterations. Another patient may have referred pain from a cervical without any neurological injury. And another may have a peripheral neuropathy that actually originates in the spine. That is why we must remember one key idea. Every cervical radiculopathy can cause cervicobrachialgia, but not every case of cervicobrachialgia will originally correspond to a radiculopathy. Now, let's give a brief description at the level of functional anatomy, an important anatomical review to properly understand this condition. To organise the examination, we can divide the anatomical territory basically into three clinical zones. The first would be the central zone, where we include all cervical roots from C5 to T1, with dorsal root ganglia, the cervical discs, and the uncovertebral and facet joints. The second would be a transition zone. Here we find structures such as the scales, the first rib, the pectoralis minor, and the brachial plexus itself. This region is especially important because the neural system passes through different mechanical interfaces before reaching the upper limb. The third would already be the peripheral zone, formed mainly by the median, radial, and ulnar nerves, each with their respective tunnels and potential sites of irritation. This division, as you can see, prevents us from focusing the entire examination exclusively on the neck. Symptoms may begin in the cervical spine and then persist due to a peripheral interface, but the opposite can also happen. That is, the patient interprets as a cervical issue a problem that is actually located in the plexus or a peripheral nerve. Therefore, we must examine the continuity of the neural system from the root to the hand, rather than studying each region as if they functioned in isolation. Let's now talk a bit and better understand the pathophysiology of cervical upper limb pain. Cervicobrachial pain rarely depends on a single mechanism. Normally, we are dealing with mixed situations. That is, mechanical compression may occur due to foraminal stenosis, a protrusion, or a disc herniation with osteophytes or loss of segmental mobility. However, the presence of a structural alteration doesn't always automatically explain the patient's symptoms. We can also see that there may be chemical inflammation around the nerve root or the dorsal root ganglia. This irritation can increase the sensitivity of the neural tissue even when the mechanical compression is not severe. From here, a neurodynamic alteration may occur, meaning the nerve loses its ability to glide, which increases its sensitivity to load and causes it to overreact to certain positions or movements. As a result, the muscular system may always develop a protective response with increased tone in the area of the scalenes, trapezius, levator scapulae, and pectoralis minor. So initially, it tends to be a defensive strategy, but if it persists over time, it can actually end up limiting movement and increasing the load on other structures, thereby worsening the pain. We must also consider referred pain originating from facets, discs, muscles, or even the fascia itself. Finally, some patients develop sensitization with broader, more variable, and usually disproportionate symptoms. Our examination determines which combination is present and which mechanism dominates the clinical picture. Let's move on to the clinical matrix, that is, the differential diagnosis. In this matrix, I summarise for you the main clinical patterns that help us relate each pattern to the therapeutic sequence. Thank you. Each pattern with the therapeutic sequence. Take note, in the cervical radicular pattern, what we expect to find is distal pain with paresthesia, and in some cases, sensory, motor, or reflex alterations. In this profile, we will always be able to use the laser to modulate pain, irritability, and inflammation, and then subsequently assess the response to traction, so that as a second step, we can then progress towards neurodynamics and exercise. On the other hand, in the case of a peripheral nerve involvement, the symptoms appear in a more specific neural territory. This means that treatment should pay special attention to the peripheral interfaces, neural bleeding, and the progressive recovery of strength. In cases related to the plexus or the thoracic outlet area, the symptoms are usually more diffuse, but they can worsen with certain arm positions that cause compression or stretching. Here, it is important to work on the region, especially the scalenes with the first rib, the pectoralis minor, and scapular control, focusing on the quality of movement in this case. Then, in a facet joint pain, or at the actual joint level, cervical pain predominates and is referred proximally. In these cases, what will be more relevant, especially regarding manual therapy, motor control, strengthening, and obviously laser therapy can also help us, but it is more specific. On the other hand, with myofascial pain, we will have referred pain with muscle sensitivity, painful spots such as trigger points. Here, we really must combine the initial reduction of symptoms with all aspects of active exercise and progressive loading. In reality, laser therapy can be included in all treatments, but in terms of differences, I have described what would be most characteristic of each one. Still need to consider the sensitized patient, where the priority will always be to reduce the sense of threat, educate in order to gradually regain movement, and progress in a progressive manner towards that functional exposure. These sequences always refer to common patterns, but they must be adapted to the individual response of each patient. They're not always 100% like this. They're what we usually tend to see. Let's talk a bit more about the cervical radicular pattern, which is one of the most common. So here, what we need to look for is a coherent combination of findings and not rely solely on a single test. That is to say, when cervical pain radiates distally, paresthesia, or that electric sensation appears, and the distribution matches a radicular territory, that's a common suspicion. Normally, the symptoms will worsen with extension and rotation or cervical compression and should improve with distraction. The clinical tests we're going to use here, thank you, in this differential diagnosis would be the Sterling's test, cervical distraction, upper limb neurodynamic tests, and the assessment of dermatomes, myotomes, and reflexes themselves. Be careful, none of these tests should be interpreted in isolation. That is, the important thing is to check whether several results converge and support the clinical hypothesis that leads us into that. Cervical radicular pattern. And when this is compatible, from here we can begin the intervention, which in the first phase is mainly aimed at reducing that pain and irritability. Here the laser really can help us a lot as an analgesic and modulatory tool. Afterwards, what we're going to assess is the response to cervical traction. Traction should not be applied solely because there is pain. That is, it should be maintained when it produces centralization, reduces distal pain, or there is an improvement in function, meaning movement. And then, in a second stage, we'll progress towards anodyne therapy, cervical exercise, and all aspects of scapular motor control. The response to treatment is part of the diagnosis and should continuously guide our decisions. Let's take a look at the diagnostic map of what our cervical nerve roots would be. Here, what helps us is the spaces. We are always talking about organising in some way that sensory, motor and reflex examination. That is to say, at the C5 level, sensitivity is mainly related to the shoulder area and the lateral region of the arm. And the assessment should be focused on the deltoid and biceps, along with the biceps reflex. At the C6 level, symptoms may reach the thumb and the lateral region of the forearm. Here, the assessment will focus on the biceps, but also on the wrist extensors and the brachioradialis reflex. At the next level, the classic sensory reference is located around the middle finger. We're now talking about C7, and we should examine the triceps, finger extensors, and the triceps reflex. Then, moving on to the next segment, symptoms appear between the fourth and fifth fingers, and the motor assessment focuses on the finger flexors. And when we move to the first thoracic space, we should observe whether the medial region of the arm and the function of the interosseous muscles of the hand are preserved, or if there is an alteration, which would be considered a positive test. What we need to bear in mind is that these territories are not absolutely rigid maps. As we've said, when we have a pattern that generally matches what we're describing, that's when we can use it as a guide. But there can always be some areas where the nerve roots overlap. So the dermatome gives us guidance, but it does not diagnose on its own. Therefore, the radicular hypothesis should be supported. The combination of symptoms, sensory aspects, strength, reflexes, the provocation tests we've mentioned, whether there is a positive response to distraction, and other clinical procedures you may be familiar with. Let's talk a bit about the pattern of what would be the peripheral nerve associated with the brachial plexus. So here we should suspect involvement of the peripheral nerve or the plexus. When cervical movement does not clearly reproduce the symptoms, or when the pain and paresthesia are predominantly distal. It can also guide us if certain arm positions increase the symptoms more clearly than cervical movements do. This already points us towards a more peripheral level. During the examination, what we will look for here is precisely sensitivity in the specific interfaces, such as the carpal tunnel, the pronator region for the median nerve, the radial tunnel for the radial nerve, obviously, and the cubital tunnel or Guyon's canal for the ulnar nerve. And in the proximal area, what we should also assess are the scalenes, the first rib, and the pectoralis minor area, because these are the ones that can alter the mechanical stress on the brachial plexus. When we want to carry out structural differentiation, we will do it through or during neurodynamic tests, which are especially useful if a distant modification carried out without directly moving the painful area changes the symptoms. This increases the likelihood of neural system involvement. The therapeutic sequence can begin with laser therapy over the relevant clinical area to reduce that sensitivity and improve tolerance, and then we address the neurointerfaces. That is, we progress towards neurodynamic mobilization and finish with strength recovery and functional exposure. The aim is not to stretch the nerve, as that would be aggressive and increase irritability, but rather to gradually restore its ability to tolerate movement and then load. Now, we are going to talk about somatic origins. That is articular, discogenic, and myofascial. Not all symptoms that extend from the neck to the shoulder or arm will have a neural origin. That is, we must also differentiate three common somatic sources, which are articular, discogenic, and myofascial, as I mentioned. In the articular facet pattern, what usually predominates is unilateral neck pain with referral to the shoulder or scapula. It usually gets worse with extension and rotation. Because we are compressing, we're scraping that facet, while the neurological examination remains normal. In the discogenic pattern, it may present as deep neck pain accompanied by a distal radiation, but less specific. It can increase, in this case, with axial loading, that is compression, sustained flexion, because the disc protrudes, or with prolonged maintained positions, such as sit-in for a long time, the so-called computer worker or office worker syndrome. In the myofascial pattern, we find a broader referred pain, with those tender points, those trigger points that reproduce the symptoms, and a protective increase in muscle tone. Here too, the neurological examination is usually or should be normal, so the differentiation does not depend on pinpointing a structure with absolute certainty, but rather relates to the coherent clinical pattern described by the patient. In these cases, the sequence normally starts with laser therapy or the manual therapy for soft tissues, and of course also includes restoring mobility and motor control, and then gradual exposure to therapeutic exercise such as strengthening. Now let's talk about warning signs within our field and when we will need to refer to a doctor, since before starting any treatment, we must confirm that the condition is suitable for a conservative physiotherapeutic approach as such. So, progressive motor deficit requires special attention, especially when the loss of strength increases or appears in several areas. We should also refer when there are gait disturbances, loss of coordination, hyperreflexia, clonus, or a suspicion of cervical myelopathy. Then, in cases of non-mechanical night pain, where unexplained fever, weight loss, or a history of cancer require further clinical investigation, this would also fall under the doctor's remit. In the case of significant trauma, additional tests may be required before carrying out any type of intervention, such as a repeat X-ray, or even for a simple trauma, for example, to rule out any type of concussion or trauma as such. We should also pay special attention to symptoms such as severe dizziness or double vision, for example, difficulty speaking, significant balance disturbances, or episodes where the patient has experienced a sudden fall. Also, chest pain, back pressure, difficulty breathing, or symptoms compatible with a cardiovascular origin should not be mistaken for or interpreted as a direct musculoskeletal problem. These require immediate attention at A&E. And finally, some serious neurological symptoms such as incontinence or rapid deterioration also require urgent medical assessment. The presence of a warning sign does not automatically confirm a serious pathology, but it does change approach as healthcare professionals. And in these cases, safety must always come before any type of treatment. Now, let's talk about the sequence of clinical examination, shall we? This is to find the path we should follow to do things properly so that we're effective and organised. We start with the medical history, which in addition is legally required, where we want to know how the problem began, what activities make it worse, what relieves it, and how the symptoms have developed over the last few days or weeks. Next, we create a symptom map, where we not only ask where it hurts, but also where the pain radiates to, whether there is any tingling or numbness, and if the distribution is constant or variable. We assess active cervical mobility and observe which movements reproduce, centralise, or reduce the symptoms. Next, we move on to specific clinical tests, where we carry out provocation or relief tests. For example, we check whether cervical compression causes pain or if distraction reduces distal radiation. From here, we then move on to the specific neurological examination, where we need to include the sensory, strength, and reflex components. From this point, we proceed to neurodynamic tests, always adapted to the patient's irritability. We are not simply looking to generate tension, but rather to achieve a relevant reproduction of the symptoms and a coherent structural differentiation in line with what the patient is describing to us. From this point, we'll palpate the interfaces to determine the condition of the scalenes, first rib, and pectoralis minor, but we have also mentioned the radial tunnel, pronator, carpal tunnel, or the cubital region. And finally, we can carry out any other brief therapeutic test or reassessment you may need. Essential questions, key issues as such. Does the neck reproduce the pain? Does distraction relieve it? Do you have any neurological deficit? We will also ask if the symptoms follow the path of the nerve. If the myofascial tissue reproduces the pain pattern, the clinical picture. And what level of irritability does the patient currently present? Let's see, because normally these can be patients who are highly irritable, right? So we are also going to classify a bit according to the level of irritability, because within these patients, these clinical cases, if they are in more acute phases or more chronic degenerative ones, our approach will also be different. So a patient with high irritability who presents with intense pain with these distal symptoms that appear very easily, which even includes sleep disturbances, with a very low tolerance to movement or examination, in this phase, the first thing we need to do is reduce the load. We are going to use the laser, either in continuous or pulsed mode at a lower dose, around energy densities of 8 to 10 joules per square centimetre. together with education, gentle offloading positions, and minimal mobility, avoiding any kind of aggressive procedure or excessive neurodynamics. What we want to do is reduce this level of irritability, especially at the beginning for analgesic purposes, to open the therapeutic window. When we're at the intermediate stage, the symptoms are still reproducible, but they are more manageable. The patient also tolerates the examination better, so we can start to introduce something a bit more active. Now we're going to combine the laser with traction and manual therapy, progressing towards neurodynamics and exercise. For example, we are getting very good results with very gentle intermittent traction. What's more, we know in early modic changes, intermittent traction can help to rehydrate the disc, which is really quite interesting. In cases where it isn't tolerated, we use a very gentle, constant, stable traction and see if we can find a position that provides relief. When we're dealing with people whose pain is more stable, there is still obviously some discomfort, but here the main limitation is functionality. It's not just about reducing symptoms, but also about the need to regain work capacity. For this profile, we do use the laser at a higher intensity as a facilitator, around 15 to 20 joules per square centimetre, and at higher temperatures, which also improves the viscoelastic component of the tissue, so we can quickly move on to all the therapeutic exercise and exposure work. Functionally, this leads to strengthening as such. The same technique may be suitable for one patient and appropriate for another, even if they have the same diagnosis and the same origin. That is to say, the most acute phase requires much more care and attention than a slightly more advanced phase. Therefore, the dosage of our treatment depends both on the mechanism and on the level of irritability. Now, in relation to this, we're going to talk about something fundamental, which is the therapeutic window. In other words, when we combine different modalities or therapies, what we want is to understand that the initial effect of the treatment creates a therapeutic window for us. Therefore, the application of the laser can help to temporarily reduce pain, modulate inflammation, and decrease that protective response of the tissue, which in turn improves tolerance to contact and movement and allows us to start working with this patient. But of course, opening that therapeutic window is not enough. It must be used immediately to achieve everything that the patient previously could not tolerate. In a radicular pattern, which is the most common and responds well to decompression, it may be the right moment to start applying cervical traction and begin making that functional change in this patient. However, for example, in a joint condition or one with a myofascial component, that reduction in sensitivity, can help us to then introduce manual therapy or active mobility work. Whenever possible, we should introduce targeted exercise during this same window, as well as all the educational aspects, so that the patient can then do things at home to help them improve. The response we're looking for is not just for the patient to tell us they have less pain, but we're aiming for improvements in functionality, cervical range of motion, centralization of symptoms, and from an emotional perspective, increasing their confidence in movement and their tolerance to exercise. The success of passive mobility is not going to be measured by its ability to facilitate an active intervention. It's not enough just to open the window, we have to make use of it. How do we integrate all of this? Well, look, the therapeutic plan, as we're discussing, integrates the different interventions with complementary objectives. That is to say, while cervical traction provides mechanical unloading in selected patients, it helps to centralize the symptoms. Laser therapy, firstly, as we've said, modulates pain, prepares the tissue, reduces irritability, and modulates inflammation. As a result, manual therapy is then aimed at restoring cervical and thoracic mobility, as well as modifying the interfaces such as the first rib, or working directly with direct techniques on the scalings or the pectoralis minor. In other words, one thing complements the other. That's why we talk about a comprehensive approach, not just applying one method or another. The different therapies don't just add up, they multiply. And it's with this clinical approach that we can truly achieve therapeutic success. And in the end, it's always exercise that consolidates the change. When we prepare our body to tolerate greater loads, it's this progressive exposure that ultimately gives us functionality. And patient education connects all these elements. In the end, we'll see a patient for an hour in the clinic where we'll open that therapeutic window and start to implement some changes. But it's necessary to consolidate the load and application with this progressive exposure of exercise by the patient in order to truly achieve long-term therapeutic success. So let's take a look, a brief review at what technology has to offer us. Within the multimodal plan, we've talked about the laser, which will be used for different purposes. First is to achieve short-term pain relief to reduce irritability, especially when there is significant limitation. To manual contact, to movement, right? In slightly more advanced stages, working with high power, high energy densities, and in contact where there is no reflection, allows us to achieve the photothermal effect. Therefore, with the correct dosage, it will allow us to reduce the protective muscular response in the cervical and scapular region, and improve sliding from a fascial point of view between different layers, enhancing the viscoelasticity of the soft tissue. This opens the door for manual therapy, traction, or exercise. Very, very interesting. Here we are combining wavelengths of 980 and 810 nanometers, and we can work either in continuous or pulsed mode if we want the dose to be delivered more gradually and to avoid the thermal effect. And with systems that can emit up to 40 watts continuously. However, as we have said, the power of the device alone doesn't determine the quality of the treatment. It always depends on the surface area, the depth of the tissue, the higher the energy density, the greater the depth, the clinical phase. During more acute phases, always lower dosages and lower power to be proliferative but not aggressive, and the pigmentation itself, right? Patients with darker skin require longer wavelengths to ensure penetration according to the patient's own sensitivity, and from there, keeping the applicator in contact always prevents energy reflection, and as the most common parameter, the total energy administered at the specific density. The aim is not always to apply more energy, but clinically to apply the correct dose according to the clinical phase. For that, you also have specific laser training courses at the Export Academy, levels 1 and 2, to really see how we work with dosimetry. Now we're going to watch a video of an application on the posterior region, so you can see an example of how we do it. Here, what we're doing is, in a comfortable and relaxed position, as you can see, the handpiece is always in continuous motion with stable contact and never staying in the same spot. The pressure should be adjusted to the patient's sensitivity. In more chronic phases, we can be a bit more aggressive, but especially in more acute phases, we should avoid being aggressive. And we must always monitor the thermal pressure. And we always avoid areas that haven't been previously assessed. Now let's watch another video where in this case we're working more on the cervicoscapular area, upper trapezius, all right? We use controlled movements, systematically covering the entire area. Notice as well what I'm doing with my free hand, all right? It helps us control the tissue, guide the movement, but always maintain an anatomical reference. The aim is to improve local tolerance and reduce muscular guarding, as we mentioned earlier in the manual therapy or active exercise section. Also, take note here in the next video how we work with gentle pressure, mobilizing the tissue itself, but there is always comfort. In other words, the pressure should not cause pain or a defensive response, and we always adapt to the anatomical pathway. Whenever you can work with contact, aside from that adaptability, notice that the treatment will always be more efficient because we avoid the reflection, which can mean a loss of between 15 to 40% of the laser energy due to reflection. So this is really a key point that makes a big difference. Well, The selection of the application area, as you have seen, will depend on what we are discussing, on our clinical hypothesis, and not just on the area of pain that the patient reports, right? In a more radicular pattern, we work on the entire cervical paravertebral region, the foraminal area corresponding to the scalenes, upper trapezius, scapular region, and basically the proximal path of the symptoms. In more peripheral patterns, the focus shifts more towards the neural interfaces, doesn't it? We can consider the cubital tunnel, carpal tunnel, and the entire clinical area involved. In more myofascial patterns, the main areas may include the upper trapezius, levator scapula, infraspinatus, pectoralis minor, and the suboccipital muscles. And in the articular pattern, what we're going to do is mainly focus on the cervical facets at the cervicothoracic junction. And always, whenever possible, target all that deep cervical musculature with high energy densities, around 15 to 20 joules per square centimetre. It's not necessary to treat all these areas in a single session. We're analysing the entire clinical picture and also working according to the patient's response. The rule in this case is simple. It's always according to the clinical hypothesis. Take note regarding dosimetry. In acute phases, I'd suggest a maximum of 8 to 10 joules per square centimetre. Normally, in very acute pathology, we'll work in pulsed mode to avoid that thermal effect and also use more controlled power to prevent that thermal effect. The dose will always be a little lower, but what's most important here is to ensure that we're working on the analgesic and biological effects without being aggressive with the tissue. In the subacute phase, we aim to restore mobility. Here, we apply energy densities of around 10 to 12 joules per square centimetre with more moderate power levels. Usually, all patients can easily tolerate 12 to 15 watts, and some even more. If possible, we'll work in continuous mode and, whenever we can, in contact, actively working on the soft tissue. What's important here is that we always use the laser before manual therapy, traction, or exercise, all right? We work both from the origin and along the entire neural pathway or all the relevant myofascial area. And in the more chronic or functionally oriented phases, the application should be much more specific and somewhat more aggressive. We're talking here that if our laser allows it, it will definitely work above 15 to 20 or around 20 watts, from 15 to 20 joules per square centimetre, always in contact and continuously to ensure the maximum energy density can penetrate and reach deep into the target tissue. Therefore, as you can see, the dose is not decided solely by the diagnosis or the size of the region. It also depends on the clinical phase, irritability, thermal tolerance, or what we are aiming for with that thermal tolerance in the viscoelastic behaviour of the tissues. Now let's talk a bit about what cervical traction would be and its clinical indications. So it will always be guided according to the patient's clinical response. We can consider it when manual distraction brings relief, when there are symptoms compatible with a radicular pattern, or when pain increases with compression and cervical extension. In these cases, traction usually works very well for patients. It is also favourable if the patient describes a clear sensation like a discharge during traction. This is good. The best response is centralization. The pain or paresthesia decreases in the area of the hand or arm and shifts towards a more proximal reaction. That's why we say it centralizes. Of course, before applying traction, we must have ruled out any warning signs or relevant contraindications, red flags, which we mentioned earlier. We are not going to prioritize it when the pain is clearly non-mechanical, when sensitization is predominant, or when there is a well-localized peripheral entrapment that is not responding to that cervical discharge. It would not be the most appropriate treatment. Nor should we continue if, when we start to apply it, the distal pain increases, more paresthesia appears, or there is a suspicion of instability or myelopathy. Traction, apart from being an intervention, is also a therapeutic test because we can see whether the patient responds well or not, which already gives us some guidance. If the response is unfavourable, then we stop and review our working hypothesis, all right? 4 specific points regarding the Triton 6E, since it allows us to combine positioning, manual therapy as well, but above all the mechanical traction, something we can't apply with our hands during programs lasting 15, 20 or more minutes, all right? And its very design makes it easier for us to adapt the patient to either a prone or supine position, all right? And for the cervical region specifically, a special feature is the ability to reposition the head between -30 and +40 degrees, which allows you to adjust the angle according to the most comfortable position and the patient's clinical response. Normally, we achieve the best therapeutic success when it is properly aligned and with intermittent programs that are not too aggressive for most patients. Obviously, technology does not replace assessment, as we've said, but it does integrate in some way. Let's watch a few short videos about the selection of different options, both protocols already included in the device, and editing minimum and maximum levels according to our clinical reasoning. I'd like to remind you that in the Export Academy, you have levels 1 and 2 to fully understand in depth the development and application, the dosimetry of all the technologies. Also, take note of how simple it is to connect the unit, the cervical accessory to the traction system and to the treatment table. We also check that the cable moves freely, that the anchor points are secure, and that there is no mechanical interference of any kind. We can see that here as well. There are also various videos showing the carabiner and how we should work with it, as well as adjusting the cervical position according to the previous examination and, essentially, to the position that best reduces the symptoms and where we can see that this traction is beneficial. Normally, we don't aim to force any particular type of flexion. Instead, we look for that comfortable, reproducible, and clinically useful alignment that improves the patient's symptoms, and of course, we use biomechanical reasoning to seek the mechanical decompression of the structure. Here we can also see how we are adjusting the treatment table, raising it slightly to align the structure, and in the next video, the patient is already fully positioned and ready to undergo that decompression by traction. The dosage of the traction basically depends on 4 main elements. The patient's position itself is already therapeutic, as are the cervical angle, the force applied, and the traction mode. The patient should always be relaxed, with their head well supported, and without any unpleasant pressure in the jaw or neck area. The angle is adjusted according to the symptom pattern. There is no single angle that works for all patients. We need to find the one that produces that feeling of relief, preferably a reduction in distal symptoms. Normally, with discopathy, a little extension or neutral extension tends to be beneficial. Whereas when we have a more stenotic component, we try to introduce a slight flexion to open up the joint spaces. The force should always be applied conservatively. We don't need to reach a high intensity for the traction to be considered effective. It should always be based on a favourable response. And usually we are getting better results with intermittent traction, right? You can also try a sustained low intensity distraction. We should only progress when that relief or centralisation occurs. If paresthesia increases, the pain moves towards the hand, or new neurological symptoms appear. In these cases, we must always stop the intervention and reassess the hypothesis. The best dose is the minimum load capable of producing a clinically useful response. The big mistake most colleagues make is thinking that the more force, the more traction, the more decompression, and therefore the better. If we go in too strong from the start, we trigger a reflex muscle contraction due to pain, and it ends up being completely counterproductive. Let's talk about multimodal protocols according to the phase, as we can basically organise therapeutic progression into 3 phases. Acute phase, calm and protect without creating dependence on passive treatment. We usually start with laser therapy to reduce irritation, accompanied by education on relieving positions, varying the load, and also managing recovery expectations emotionally. If distraction produces a favourable response, we introduce that gentle traction as soon as possible. We can also use low-intensity manual therapy, that specific cervical mobilization as well as thoracic within comfortable ranges, and exercises based on breathing and motor control, especially targeting the deep stabilizing muscles. In the subacute phase, the aim is always to recover movement. That is, the laser continues to help us as tissue preparation, but here we must always bear in mind that once we open the therapeutic window, within the dosimetry we discussed earlier, we progressively increase active participation. We select traction or manual therapy according to the clinical pattern, and we now introduce gentle neurodynamic mobilizations with control of the deep cervical plexus, scapular control, and thoracic mobility. As we move into a third phase, the patient now needs to start associating their improvement with their own ability to move. Here, what we want is to consolidate function, where in fact, at this point, we use the laser as a facilitator, and the treatment is basically focused on cervical and scapular strength, on progressive neurodynamics, and on exposure to tasks relevant to the patient. In terms of education, a home program that includes self-management, movement, strength, and progressive load management is essential to ensure clinical success. Let's move on to this executive summary by explaining a real integrated clinical case. We have a 46-year-old patient with right-sided neck pain that has lasted for 3 weeks. Notice that the pain radiates towards the lateral region of the forearm and thumb with intermittent paresthesia. The symptoms worsen when working on the computer with neck extension or with rotation to the right, in other words, unilaterally on the same side. On functional examination, the Sperling test is positive and reproduces the symptoms. Cervical distraction provides relief, and the neurodynamic test of the median and radial nerve areas reproduces the symptoms, but there is no motor deficit. With this information, the main hypothesis is radicular pain related to the lower mid-cervical region, isn't it? At the level of the radial nerve, we're talking about a moderate level of irritability. Why can't we diagnose it solely based on the fact that the pain radiates towards the thumb? Because the hypothesis, as we've said, is based on the distribution of symptoms, the response to compression, the relief when we apply distraction, the neurodynamic test, and the absence of progressive motor deficit. Therefore, before starting treatment, we confirm that there are no warning signs, that is, those red flags requiring medical referral, symptoms compatible with any type of myelopathy or any other non-musculoskeletal origin. From here, the plan would be to apply treatment to the cervical, scapular, and scalene region, around 12 to 15 joules per square centimetre, continuous power of 15 to 20 watts if possible, always in contact with a medium thermal effect, but always comfortable. And from here, it's not about curing the nerve root, nor doing so in isolation, but rather about reducing irritability to prepare the patient for mobility and unloading, first of all, and then to continue with all the therapeutic exercise work. If, during traction, we also observe that the pain becomes centralized, the peripheral paresthesia decreases, and the patient feels a sense of relief, that is very positive. So we are already moving towards a patient with less pain, where we are going to take advantage of this window to introduce all the specific cervicothoracic manual therapy, all the neurodynamic mobilization at the level of the peripheral nerve with sliding and amplitude that does not increase irritation, and all the exercises for deep cervical control and postural control, all right? That's what we would be aiming for then. So to wrap up, as a conclusion, what I want to say to you is that the most important thing, as you've seen, is that we always start with a safe assessment and a well-structured differential diagnosis. This is the foundation of any good treatment. Laser therapy can reduce pain and prepare the tissues. Traction will be useful as long as it provides decompression and centralization of symptoms. And manual therapy can improve mobility and mechanical interfaces. But exercise, education, and gradual exposure are the elements that turn temporary improvement into functional recovery. Thank you very much for joining us for this training from Anobis Medical Education at the X4 Academy. And now we'll move on to the Q&A session.